Hello. Thank you so much for having me as a moderator for the very first panel. It's an honor to moderate this special panel on emerging research on cancer. So let me just introduce the first speaker, Ms. Merlita Opeña. Ms. Opeña is the focal person of the Philippine National Health Research System, led by the Philippine Council for Health Research and Development, Department of Science and Technology. So Ms. Opeña, if you wish, please.
Dr. Tremi Wan, SecGen of APRU, former Secretary of Health, Secretary Ona, the UP Executive Vice President, Ted Arbosa, the UP Manila Chancellor, Menchit Padilla, distinguished guests, experts, resource persons, ladies and gentlemen, good morning. The Health Research Council of the Philippines is pleased to share with you the programs that we're supporting as a funding agency. So that's our council, the Philippine Council for Health Research and Development, and we provide leadership and direction on health research for better health outcomes. And we're the lead agency in the Philippine National Health Research System, which was enacted into a law with our pillar institutions, the Department of Health, Department of Science and Technology, the Commission on Higher Education, and the University of the Philippines, Manila. So how do we help health research in the country? We provide access to research funding, not only from the Ministry of Science and Technology, but also from the Ministry of Health and the Commission on Higher Education. And we promote research idea into utilization. So whether they are for knowledge and further research or commercialization. In the country for the next 6 years, as part of the Philippine Development Plan, we have a national, a harmonized national research agenda, crossing basic research, health, agriculture, to industry, to disaster risk reduction. For the health sector, for the next 6 years, 2017 to 2022, we have drafted, we have actually finalized the National Unified Health Research Agenda. Unified meaning it's from the Department of Health, the Science and Technology, Higher Education, and all the partners in the Philippine National Health Research System contributed to the crafting of the national research agenda from all the regions, all the 17 regions of the country. And these are the key areas, key themes within that agenda. And within the research agenda, in terms of technology development and where the science, technology, and innovation funding will go, would be the areas of diagnostics, drug discovery, down to climate change and the omics as a platform technology, both for communicable and non-communicable diseases. Some of the researches that we have supported in terms of genomics, in the areas of genomics, are on lung cancer, on colorectal cancer, and the program on antibody and molecular oncology. And in terms of drug discovery, we have established 10 universities to be centers of research in natural products. And some of them, 3 of them here are doing research on indigenous plants as source of therapeutics for cancer. And there are also studies on anti-infectives and anti-cancer from marine sources. And from the drug discovery program, they have come up with 35 herbal drug candidates and 100 compounds, as well as in the functional foods and diagnostics. Here, I'd like to introduce to you a program which was launched by the Ministry, the Department of Science and Technology. We call it the Science for Change program, in which it will build centers of excellence in research, not only in Metro Manila, but also in the other 16 regions of the country. And the launch was started last May. And in the first round, in terms of the health sector, what we have endorsed there was the Center for Research in Disaster Health, um, Disaster Risk Reduction in Health. But based on the discussions today, there could be other centers that could be developed, um, which would be under this program. And side by side with this program is the R&D leadership program, in which we can engage experts from the Philippines as well as from the international community who can help build the centers. So we're just starting in terms of the call for proposals. We are just in the second round. So there could be other centers of excellence which will be of impact on global health. The next two would be support working with industry. The, the acronym CRADLE is really industry defining the problem and engaging a university to find the solution. So we call it the CRADLE program. The, the other one is supporting industry in their R&D programs. So it should be important that industry has an R&D program to avail of this program. One of the most important or the important thing in health research is we really thrive on collaboration and linkages. And the Philippine National Health Research System as a system is already a collaboration, but we also have international collaboration like the one with UK, the Medical Research Council, and there's a new signed MOU with the NIH in terms of infectious diseases, starting with TB. And I think we have also the Japan E-Asia program, and with Taiwan, the Mekoteco programs, among others, as well as with the ASEAN, of course. And in terms of supporting research, we not only support research and fund it, but we start from defining the research agenda, the national research agenda, programs on capacity building, um, helping institutions in their ethics review boards and in their accreditation, organizing information resources so that this will be easily accessible by researchers, and importantly, translating research results into policies, actions for the health professionals, and even into products and services which industry can pick up and commercialize so that the households can have access to them. So I think this is the last of my slide. Thank you very much.
Thank you very much, Ms. Opena. The next speaker is Dr. Clarito Cairo. Dr. Cairo is a medical officer from the Disease Prevention and Control Bureau Lifestyle-Related Disease Division of the Department of Health. He has been with Department of Health for 5 years now. He is presently the National Program Manager of Philippine Cancer Control, Palliative and Hospice Care, and Thyroid Disorders. So Dr. Cairo, please, if you wish.
Good morning, everyone. So I will give you a short overview of the Philippine Cancer Control Program. Cancer in the Philippines remains the third leading cause of mortality among the Filipinos, next to heart disease and stroke. And based on the 2015 Philippine Cancer Facts and Estimates, which is a joint project of the Department of Health and the Philippine Cancer Society, here's the estimated new cancer cases and deaths. Out of 109,000 cases, we have 66,000 deaths. And breast cancer, or breast, is still the leading site of cancer incidence. And lung is the leading site for all cancer-related mortality. And you can see here, breast has better survival, unlike lung and liver cancers, which have poor survival. So here's the vision, the direction of the Philippine Cancer Control Program. Our vision is comprehensive cancer care and optimize cancer survival in 2025. And our mission is to reduce the impact of cancer and improve the well-being of Filipino people with cancer and their families. And here's the continuum of our cancer program, from prevention to screening to diagnosis, including palliative and hospice care, treatment, and rehabilitation or survivorship. So for prevention, our cancer awareness campaigns, we have lots of awareness campaigns for different cancers. And then we have vaccination in place for hepatitis B and school-based HPV immunization. And for legislation, we have a good example is sin tax law, the passage of sin tax law under the leadership of our Secretary, then Secretary of Health, Dr. Enrique Ona. So it's a big help. The excise taxes of alcohol and tobacco is dramatically increased, preventing some 1 million smokers from continuing their vice. So for screening, we are planning to have this in place, especially once the Universal Healthcare Bill will be enacted, and the cancer bill is enacted as well, the Cancer Screening Access Program. That is providing free screening tests for at-risk populations in the hospitals. And mobile cancer screening buses for the far-flung areas. And for the diagnosis, we now have this cancer medical assistance program in the DOH hospitals just early this year, wherein we provide assistance to all cancer patients because we see cancer as a catastrophic illness. That's why we need to help them financially. And then we have treatment. We have this medicines access program. We provide free cancer drugs in selected DOH hospitals and selected cancers, like breast cancer, childhood cancer, colorectal cancer. This year will be provided. And for palliative and hospice care, we now have the national policy on palliative and hospice care, because based on the 2015 Quality of Death Index, Philippines is the third worst place to die. So we need to address that. Out of 80 countries, we're the third worst place to die. And for rehabilitation and survivorship care, we are planning to have the national policy on rehabilitation and survivorship for cancer patients. So, to further elaborate the program, our vision, comprehensive cancer care and optimized cancer survival in 2025, is anchored on our Philippine Health Agenda 2016 to 2022. But since 6 years is short to achieve the universal health care, so we put there and beyond. And the goals of the Philippine Health Agenda is financial risk protection, better health outcomes, and responsiveness. So first and foremost, our cancer patients should be given financial assistance. Out-of-pocket expenses should be reduced or eliminated. And based on the Sustainable Development Goals of the United Nations, it's written there, end poverty. So that's part of our financial risk protection. And for Ambition natin 2040 and Asia 2050, that's the Filipino dream, our aspiration. By that time, the Filipinos will live long and healthy lives, and Philippines will be one of the strong economies in the world. So that's our end goal. And for the game plan, this is our strategies: research, training, and development. So research is very important for the program. As they say, data is the new oil. So we have to invest on research, especially local data. And cancer registry and surveillance, cancer screening access program, medical assistance program, field health benefits, our health insurance. And then we have this National Integrated Cancer Control Act. This is still pending in our Congress. This is a priority bill of this administration, and hopefully before the 17th Congress ends, this will be now a law. So once this becomes a law, this will institutionalize the Philippine Cancer Control Program. And of course, we cannot do it alone in the DOH. That's why we have a lot of partners. So we have to collaborate with multi-sectoral, multidisciplinary, multi-stakeholders. And this is our cancer web. In the middle is the program. We need to collaborate with several partners and stakeholders. In the far right, the Health Policy Development and Planning Bureau will now be the clearinghouse for all the clinical practice guidelines. And the CPG will now be the basis for the procurement of our cancer drugs. And we have the Health Technology Assessment, which will be under also the Health Policy Development and Planning Bureau, as well as the Research Institute, especially once the Universal Healthcare Bill is enacted into law. And in the middle, we will be establishing 22 cancer centers nationwide at DOH hospitals. And once the cancer bill is enacted into law, we will be having 5 designated comprehensive cancer care centers in strategic regions of the country. And of course, we have various sub-programs, like the cervical cancer sub-program in collaboration with the JPIGO Philippines and Cervical Cancer Program, Pediatric Cancer Control Sub-Program in collaboration with the Philippine General Hospital, Philippine Children's Medical Center, and Southern Philippines Medical Center. And lately, we are planning to have a blood cancer control sub-program that includes leukemia, lymphoma, and multiple myeloma in collaboration with the Philippine Society of Hematology and Blood Transfusion, as well as the Philippine Society of Medical Oncology. And for research and development, we will also partner with the UP, NIH, Institute of Health Policy and Development Studies. So here are the notable milestones, three-phase journey. For the phase one, we expect to have the National Integrated Cancer Control Act before the end of the 17th Congress, and the Philippine Cancer Registry, both population-based and hospital-based. And for the next phase, 2019 to 2022, we have the 22 cancer centers in place and the 5 designated comprehensive cancer care centers. And for the last phase, 2022 to 2024, the program will be institutionalized and sustained. And by 2025, we hope to achieve the vision. So here's the initial program core indicators, 12 of them, divided into inputs, outputs, outcomes, and impact. For the inputs, we will be targeting the incidence of cancer by type and age bracket based on WHO, 0 to 29, 30 to 69, 70 and beyond. For the outputs, so for the recipients of the HBV vaccine, hepatitis B virus, as well as the school-based HPV vaccine. And then for the outcomes, the patients with cancer who avail the following: field health benefits, medicines access program, medical assistance program, and the Philippine Charity Sweepstakes individual medical assistance program. And for the impact, we target the 5-year prevalence or survival rate of cancer by age bracket. So the Philippine Cancer Control Program is the first program to harmonize the registry forms together with PhilHealth, together with the Philippine Cancer Society, the Cancer Registry Care Philippines, and the Epidemiology Bureau. Because by next year, DOH and PhilHealth shall mandate the use of electronic medical records in all health facilities. So DOH, in collaboration with academic partners and research institutions, shall facilitate ease of access of researchers to available data. So here's our priorities for the program. First and foremost, we need to establish the infrastructure. So the Philippine Cancer Registry should be in place in the first phase, both population-based of the Philippine Cancer Society and hospital-based care of our Cancer Care Philippines, and biobanks, cancer biobanks in selected DOH hospitals. And we need to have stable funding. So clinical practice guidelines is the highest level of evidence. So that will be the basis of our cancer commodities. And we need to collaborate with our stakeholders, our academe, our specialty societies, even our patients. So this is what we plan to do for the biobanks. We need to partner with GlycoProX, which is the brainchild of Mr. Aldo Carrascoso, a Filipino who is based in Silicon Valley. Is willing to help us in biobanks, in the establishment of cancer drug target factory. They will digitize the blood samples for future research, for efficient diagnostics and breakthrough medicines for cancer. So that will be the goal of their company. And initially, within Metro Manila, we will provide biobanks in 10 DOH hospitals. So this is my last slide. According to our President Duterte, our cancer champion, during his last State of the Nation address, investing in the health sector is never a cost to be endured, but an opportunity to be explored. Thank you very much.
Thank you very much, Dr. Cairo. Now we have the last speaker, uh, Professor Martin Won. Professor Won is a specialist in family medicine and an expert in the field of colorectal cancer screening and cardiovascular pharmacology. He is a reviewer for the Medical Research Council, United Kingdom, and an external reviewer of the Public Policy Research Funding Scheme, Research Grant Council. Professor Won, wish, please.
Thank you very much for a very kind introduction of our chair lady. And ladies and gentlemen, and also all our honorable guests, is a true privilege of the team from the Chinese University of Hong Kong to be able to present here. And we feel very privileged to meet all very important guests. And the topic today is on the strategies to enhance compliance to colorectal cancer screening. And we declare that part of the result has been published in JAMA Oncology. Well, as we all understand, and also previously alluded to by our very renowned speakers, cancer is still actually one of the very important priorities as identified by the World Health Organization. And we need to actually deal with it. For instance, taking Global Can 2012 data, an estimated 1.2 million patients suffer from colorectal cancer worldwide. And there's been a rising trend of this cancer incidence, mortality, and a number of other aspects in the different countries, and namely more so in the more developed regions as compared to the less developed one. And the mortality actually accounted for 8.5% of the total cancer deaths in the world. And therefore, it actually brings our attention to the recent 2 to 3-fold rise in its incidence and mortality. And this actually is we need to be really cautious. Just a sharing on the cancer incidence trend and mortality trend in Hong Kong, we recently come across a rapid rise of colorectal cancer incidence. And in the year 2012, we can see the incidence of colorectal cancer actually surpassed lung cancer as the #1 cancer, the most common cancer. There are other cancers which are related to affluent society and also lifestyles, including breast cancer and prostate cancer. They're also rising in a very alarming manner. Therefore, we have to do something before it's actually really too late. And luckily, these 3 rising cancers has a very high incidence to mortality ratio. And this ratio is in fact a proxy measure of whether these cancers could be screened at their early stage and identify early stage cancer so that late stage cancer can be prevented. As we can see here, there's a very large gap between incidence and mortality for colorectal cancer, breast cancer, and prostate cancer. And there has been numerous literature talking about the progression of colorectal cancer will be initially from hyperproliferation to polyps to adenomatous lesions, and then to a stage in the very early benign sort of stage, we can in fact remove the early lesions so that the later stage cancers such as adenocarcinoma and stage 3 or 4 cancers can be prevented, because this actually induces a very substantial global health burden, requiring operation, chemotherapy, and radiotherapy. And this would also induce burdens on our healthcare system in terms of health services utilization. Now, there's been substantial copies of studies talking about screening effectiveness, which could reduce mortality by more than 33%. So before and after screening, for males and female, we can see there's been a reduction of mortality due to colorectal cancer by approximately 30% and even higher by the other mortalities. So initially, what we've been talking about would be qualitative fecal immunochemical tests, whereas the test itself would give you a result of whether the patient is suffering from having fecal occult blood test being positive or negative. And now we have quantitative FIT, which is a tool giving you a number. And this number is the exact concentration of hemoglobin being detected by the machine. And this will allow adjustment of the cutoff point, whereas positive or negative FIT could be more precisely defined. And the fecal occult blood test is actually very easy to use. For instance, this is a very simple collection tube. This is a test cassette, and the screening participant will only need to actually unscrew the tube and then collect from the different pieces of their fecal specimens, and then after collection, it can be returned to the physician's office. And afterwards, a very simple office-based test can be performed by the physician, and within 5 minutes, the patient will be able to know whether he or she is actually suffering from cancer, and then we can see positive and negative result, very easy to be distinguished. So there are a number of countries that have already implemented population-based colorectal cancer screening, including Japan, Korea, Taiwan, and a number of countries in Asia Pacific region, including in India and also mainland China. Yet Hong Kong, before 2017, does not have any population-based colorectal cancer screening program. Yet the Chinese University of Hong Kong team, led by Professor Joseph Sung, has had a meeting, and that conference has updated what we call the Asia Pacific Consensus Recommendations on colorectal cancer. And there are a number of important recommendations which have been adopted extensively by Asia Pacific countries, including statements such as stool-based occult blood testing is of proven value for population-based screening, and then Guarac-based stool testing should be replaced by FITs, fecal immunochemical tests. And this landmark consensus recommendation has published in a prestigious journal named Gut. And then there have been more and more stakeholder engagement to ensure that the other Asia Pacific partners would really consider colorectal cancer screening being implemented, not only in a particular region, but also in different countries in Asia Pacific and extending to a wider sort of area. So after engagement of international experts and authorities this is actually a picture taken in the Chinese University of Hong Kong campus. And after the consensus recommendation, there has in fact been a colorectal cancer pilot program being implemented by the Hong Kong government. And we're now very pleased to see that in Canada, United States, Europe, and a number of other countries in Asia Pacific, including Hong Kong now, got colorectal cancer screening program, which is population-based and also subsidized heavily by the government. So what's the clinical problem we have been encountering? In fact, we identified one key success factor for organized population-based screening program, namely that persistent adherence to the program. If one actually has been enrolled into the colorectal cancer screening, that particular subject will need to have regular follow-up over time. So we recommend 1 to 2 yearly follow-up if they take up fecal immunochemical tests. Unfortunately, it is actually really quite common to observe decreasing adherence over time in primary care. In the past, we have studied more than 5,000 individuals who are screening participants for colorectal cancer. In year 1, 97% of people turn up for colorectal cancer screening. Whereas for the second and third year, you can see for year 4, the proportion of people attending for colorectal cancer screening is declining. Whereas when we talk about screening of this cancer, we're expecting people aged between 50 to 75 to be enrolled. So if a person is age 50 and go for colorectal cancer screening, would expect the person to be persistently screening over time in order for the colorectal cancer screening test to be effective and also if cost efficient. So we are really wondering, can we use some telecommunication strategies by primary care professionals in our context so as to enhance the screening rate? There have been few studies which have compared the impact of automated versus interactive telephone calls on enhancing adherence rates. So our research objective is to compare among different subjects, where some subjects have been given interactive telephone reminders versus those given short message services, what we call SMS, and also usual care. That means there's been no additional reminder. So the methodology is a randomized parallel group open label trial and conducted in a primary care setting in Hong Kong. The eligible subjects are screening participants who joined a population-based screening program in the year 2015 in Hong Kong. And they are asymptomatic subjects aged between 40 to 70 with negative FIT results. And then they're expected to come back 1 year later to get their fits. And upon program enrollment in the year 2015, those participants were invited to repeat the second year FIT, which is free of charge. So we run a randomized control trial. We have an allocation ratio of 1:1. And then, one subject would have an equal opportunity to be, or probability to be allocated to either one of the three groups, namely interactive telephone reminder, and SMS message, and usual care. And then they're blinded to the intervention after receiving the messages. So we capture the data 1 year after the initial screening and give a grace period of 1 month. And there are 3 different groups, and then the SMS group will be receiving 1 message, and the telephone group would have a professional in primary care who actually give them interactive telephone reminders. And then the participants are actually allowed to ask questions and all their queries being clarified by the primary care professional. And as we can see here, this is the flow diagram. And luckily, we have a very few people dropping out. And then in the control and SMS and telephone group, we have approximately 205 subjects. So this is actually the baseline characteristics of our participants, showing that all the p-values are not significant, namely that the initial baseline characteristics are similar and therefore comparable in subsequent analysis. So this is actually the result. When we are measuring the 2 primary outcomes, one is the collection of FIT, one is return of FIT. So for collection of the FIT chip 1 year after the initial enrollment, those who have been assigned to the telephone group had the highest proportion coming back for follow-up, and then followed by the SMS group, followed by the usual care group. And how about return of the completed FIT specimen? We're talking about 91.2% being able to return the specimen if they've been given a telephone reminder, comparing to control, whose proportion is only 9.1%. So it's actually a very significant difference among the 3 groups. So we use regression analysis to study the adjusted odds ratios. We can see that the SMS group and telephone group, they perform significantly better as compared to the control group. Whereas if we only compare the SMS group as the reference group and telephone group as the case. So we can see that the telephone group also perform slightly better than the SMS group. And then how about 6 months after date of expected follow-up? Because we are not only measuring 1 year after the enrollment, we are also interested to know how about after that 1 year, and extend the observation to 6 months later. We can see that the telephone group still perform better than the other 2 groups, whereas the SMS group is no longer so-called effective as compared to the control. So we might probably ask, what's the magic of an interactive telephone reminder? It's only 1 telephone call. Now, in fact, we have actually checked some of the literature and have some reading and find that a telephone reminder will be actually really able to enable the individual to plan their attendance to the screening appointments, and only consists of a very simple telephone conversation, highlighting on the importance of CRC screening, and also act on the predisposing and also reinforcing factor, or what we call the precede-proceed model, which is a behavioral health model. And then also interactive telephone will have a personal reminder element that's probably absent in the SMS group. And from the literature, we understand that automated telephone calls were highly cost effective. We only need $40 US dollars per additional screenee in order to achieve one more attendance. So telephone calls may represent an operationally feasible and practical approach to be adopted in primary care. So, however, we have to be aware of the limitations of this study. It was only conducted in one single center. Its generalizability might be challenged. We only observed the subjects for only 1 year, and we need to assess the sustainability of all these strategies. And for instance, in some regions which are relatively underprivileged, they might not have mobile telephones. And also all these subjects in the screening practice, we're really talking about self-referred subjects. So I have a chance to discuss with all the VIP guests and also our very renowned speakers. They do really think that, well, if your trial is a single center study, how about if we actually work together collaboratively and run multi-center trials to ensure that its generalizability can be further enhanced? So in fact, these findings are actually supporting the effectiveness of interactive telephone reminders delivered by primary care professionals, and to a lesser extent SMS messages. But I would think that, well, in fact, the study is actually very limited in the sense that we only got a single center sort of study. So we need to work together. And thank you for APRU giving us a very good platform. And then I'm sure that we can actually work together and also form collaborative partnership and initiative to further assess the different effective strategies which could actually enhance screening rate. So of course, this study also highlighted the important role played by all of us here. You will be the very influential, no matter your policymakers, your academics, or your service provider. You are all very important in enhancing screening for cancer and reducing its morbidity and mortality. So this is my last slide. This is actually the logo of our colorectal cancer screening project. It consists of this shape, or it's a character. It's called Ta. Okay, it's big. Well, it's we really talk about our large intestine. And also this is a person with that particular question mark. It represents the colon. But the question mark is very important. There are still many research questions being unanswered, and we need really to actually work together. So this is the message. And thank you so much. I hope we'll have time to be Hong Kong. Thank you.
Thank you so much, Professor Wong. It was a very good opportunity to learn about or obtain new latest information on cancer research and policy making. Now I'd like to open the floor to any questions, and also questions on keynote by Dr. Harris are also welcomed. Would anybody like to ask any questions? I can't see. Yes. Probably microphone. So, gentleman there first, and after that.
I have a question for Dr. Harris. So thank you for your presentation. I was trying to understand the connection with precision medicine and public health has been a challenge for a lot of us, and I think you've really helped us understand that a little bit more. But one question I have is a study that myself and a colleague at USC is doing on cancer mortality and incidence in Los Angeles County. We've seen stability in the disparities in cancer incidence across the county by economic status. And it seems that if we focus too much on just looking at the genetic differences that can account for differences in cancer rates, are we ignoring some of the broader social factors that I think are almost like low-hanging fruit that we can address more quickly without the more expensive approach into precision medicine. I don't know if you could comment on that.
I agree with you, agree with you completely. And part of that is access to those kinds of screening, if you want, or just being involved in various studies and getting, convincing people, giving them the opportunity and helping them, because sometimes they can't get away from their job or various other things, so that they can participate in prevention efforts. So I think that's extremely important. And one kind of study that was done that we've collaborated with by Bill Blott was the Southern Community Cohort Study, in which it was a prospective study in which there was essentially equal number of Afro-Americans and European Americans, and economic status and a whole variety of other things were asked, and opportunities for low-income people to participate were part of it. And that proved to be extremely important in regards to doing the analysis of not only cancer rates, but also the effectiveness of screening. So I think that's my general comment. That's quite an excellent question. So genetics isn't everything. It's tough to choose your parents.
Dr. Padilla, professor from UP Manila. I'm a geneticist, so I really did appreciate the lecture of Dr. Harris. And thank you for reminding all of us that genomics is important for prevention, for early diagnosis and treatment. So I do want to share with the group, as well as the audience who may not be familiar, that the University of the Philippines actually is working on cancer projects right now. We're looking at biomarkers so that we can identify markers that will be helpful for early diagnosis and treatment. And the Philippine Genome Center, there's a Philippine Genome Center in the Philippines, together with the Philippine General Hospital, will be coming up with landmark projects actually to identify markers that will affect the treatment algorithms. So we do want to probably work with you and see whether we can refine those findings. From my experience as a geneticist now for almost 3 decades, the markers in our population is different from those from the Caucasian population. So we have to come up with our own projects since the Philippine Council for Health Research and Development is here, we depend on them for funding. And we will need to invest on this. If we want to help our population, then we have to come up with our own studies to look at our own cancers so that we can partner with the Department of Health in coming up with this big cancer program. So I just want to thank you for reminding us that genomics is important.
Yeah, you make an extremely important point that, first of all, international collaborations are important, because then you can compare cohorts from different countries and different aspects of different countries. And what might be useful for the European Americans in the United States in terms of screening was not necessarily useful for the Afro-Americans. And so that was an example that I gave in terms of health disparity. So how do you deal with all that? One of the ways you deal with this is actually set up collaborations and with international groups and collaborators in different countries and with different backgrounds, genetic backgrounds, but just different social economic status, and see if the results in one country compare with another country. And international collaboration is synergistic. It's something that I'm definitely wedded to do, and we do, including here in the Pacific Rim. So this is cancer research is international, and essentially all research is now international. So take advantage of the ability to collaborate with colleagues. And meetings like this are an opportunity to interact and actually form those kinds of collaborations.
Any other questions? Okay, thank you very much. I'd like to, shall we close the session now? So I'd like to thank all the three speakers and Dr. Harris again. Thank you very much.
For the special panel on academics and policymakers, I'd like to call on Associate Dean Xiaoxia Chen from the College of Public Health, National Taiwan University to lead the discussion. Let's give him a warm round of applause.
Good morning, everyone. This is the second panel. We are talking about academia as policymakers. My name is Soxia Chen. I'm from National Taiwan University. In addition to teaching at the university more than 20 years, I have been serving in the government as the CEO of the single-payer national health insurance in Taiwan. So I'm qualified to join this panel. And today we have two distinguished speakers. The first speaker will be Dr. Ona. Professor Ona is a former Minister of Health in Philippines. And actually, he's a famous surgeon in vascular surgery and organ transplantation. And so let's welcome Dr. Ona, please.
I wish to thank the panel, the organizers of this session for inviting me, and I'm happy to participate in this discussion. When I was invited to speak on this so-called special panel on how academics can adjust themselves when they become policymakers, and especially in implementing health reforms, I thought this was a very interesting subject, because with this audience that I see this morning, some of you are at least advisors to policymakers, and a good number of you will become most likely either ministers or secretaries of health of your country and will become the policymakers. I thought this was an interesting question, and I assume that the topic may refer to an academic with little or no public health or public work experience. Although in our local setting here in the Philippines, we as professionals are what I call a hybrid of medical practitioners exposed to both environment, meaning in the academe and to a certain extent in government, and at the same time also are allowed some leeway of private practice. For example, in my instance, my role as a health policy maker came as a period when I had almost more than several decades of work experience, both in the private sector, in the academe, and the last 12 years of my work was as a medical director of our specialty institution in renal care. So I think that the training in the scientific method, solving problems systematically as a second nature, comes to us when you teach and do some research in the university. In general, my background was a residency in surgery for more than 8 years. And in this particular instance, I believe that kind of work was the equivalent of a formal master's or a PhD, and a work or a whole-time life experience in also private practice, and doing at the same time some clinical and basic research with our partners in the university. So therefore, the academic nature of our work exposes one to access to a wide network of expertise. And so this made securing advice from other experts easier. And as a matter of fact, when I assumed that position, I thought that the recruitment of expert staff was quite easy for me because a good number of them I had worked with. At the same time, the academic exposure that we have brings or gives us openness to new ideas, very frequent discussion and debate. And as a medical doctor and academic, and working with the multidisciplinary teams, this prepared us to, at least in my particular case, an invitation when I was asked to join the government. As was discussed earlier this morning, there is tremendous issues that will have to be given priority when working or when you now become the policymaker. As will be shown in health alone, you have here this morning a discussion just on cancer. And on the next day or so, you'll be discussing about nutrition and the whole gamut of health problems that confines or confounds your country. And so therefore, prioritization is something that will have to become a very difficult issue when one becomes a policymaker. And of course, we talk always of prioritization in health and the value for money. And when I say value for money, what is the best area wherein one would give priority to a particular problem that confronts the national health of a country? For example, I was asked to kind of relate to you certain experiences that I had that made it easier for us to pass what I consider the three most important legislation that the Philippines had in health during the last at least decade. First was the passage of the responsible parenthood and reproductive health. When I assumed the position of Minister of Health in 2010, the reproductive health bill had been filed in Congress, but could not be passed for the past more than 10 years. And any attempt to pass one during those previous years never progressed beyond the lower house. And I believe that the reason was essentially a perception that the bill was essentially, in the Philippines, an effort to control population. And at that particular time or in the past, the reproductive health was considered as an issue not only to control the population, but to do it through abortion. And in the Philippines, being a Catholic country with 85% are Christians and mostly Catholics, it was very difficult for the legislators to pass any bill that would allow either other methods of contraception, much less with abortion. And so our strategy then was to change not only the title, of the bill, but make it appear that it was essentially not a population control measure, but that it was a measure for proper planning of a family to good health as a result of spacing of your pregnancy, as well as improving or reducing maternal health care or maternal mortality. I myself was an observant of the period in the United States in the 70s and the 80s when abortion was very common. And so in the Philippines, reproductive health essentially is associated with abortion. And by just changing the title of the bill from reproductive or family planning to a title emphasizing maternal health as well as family health, we were able to convince most of the legislators in eventually passing the bill, not only in the lower house, but also in the upper house. In much the same manner as when the sin tax was a big debate in the Philippines. The biggest funder for our politicians is really the cigarette industry. And so during the debate, we proposed that the discussion be centered mostly, if not entirely, on health, rather than on the raising of the funds for public health or for other measures. And just on this tactic alone, we were able to eventually pass the sin tax that tremendously increased the budget, since that budget or that fund that was generated by the sin tax, 85% of that was specifically allocated to public health or to the health of our people. And that debate that was brought to the public eventually convinced our legislators through the pressure of the public that eventually resulted in the passage of the sin tax. And this is why we in the Philippines today have been able to increase by more than 5 times our budget on healthcare. At the same time, we were also able to amend our field health law that now allowed a very aggressive enrollment of all Filipinos. The field health law in the Philippines mandates that all Filipinos will have to be covered by our universal health care program, and that the poor Filipinos, which number something like 25 to even 35 million Filipino family population, should be covered by a premium that will be paid for by the national government. And a big part of this available funds was generated by our sin tax. So in short, as academics, we were able to convince our legislators to pass all of these very important health bills in the country by working very closely with them. However, we tried the strategy of using health, essentially, health as the reason why you are passing a law, and not because of some other areas like, for example, raising money or taxation. And so I think it is very important for a strategy that gives you a leeway in making the debate on any passage of a health care or a health bill possible by just being able to use your experience in the academe and using the assistance that the academic community can give you. And this is what I think has been responsible for our ability to make these three major legislative bills that made healthcare improve in our country today. Thank you and good morning.
Thank you very much, Dr. Honor. It's a great, inspiring talk. Our next presenter is Professor Kai Hong Hua. Professor Paul is a professor at Lee Kuan Yew School of Public Policy at National University of Singapore. Professor Paul is a well-known health policy researcher in the Asian area. Okay, let's welcome Professor Paul, please.
Thank you. I'm standing between you and lunch. So I'm going to be very efficient in covering the 15 slides that I have. I've been here almost every year in the past to consult either for WHO regional office or the ADB or sometimes some of in the past, the Department of Health activities. And that's when I first met Dr. Ona, when he was CEO more than 15 years ago, when I was doing a consultancy here for the DOH on behalf of WHO. And since then, I've been coming, I think the last few years, last year I was here upon the invitation of the Academy of Science, and you were pushing very hard for university health coverage and equity. And the year before, I was invited to come to talk to a health research, international health research meeting, I think the CORED meeting. And so you took the opportunity as usual, to initiate a young leaders for health forum. I was invited to be one of the speakers. So I'd like to share with you some of the slides that I had prepared actually 2 years ago for this group of young leaders. And I see many of them here. And this is our promise for the future of trying to implement some of the scientific facts and what has been happening in the rest of the world to bring it to our part of the world. So I'd like to share my own journey in public health and what has brought me into global health. Because I started out in the medical school as the first health economist more than 20 years ago in the University of Singapore Faculty of Medicine. And so dealing with the scientific community and getting the science correct was the basis on which we have to base our health policies. But then translating the science into action requires a lot of social sciences and public policy tools, and which I have been privileged to be involved in the setting up of the Lee Kuan Yew School of Public Policy over the last 12 years. So I'd like to maybe trace my own journey and share with you some of my own experiences, and perhaps you can identify or relate to some of this in your work in public health or global health. Let me just try and figure out how to move this. All right. Sorry. Okay, here, okay. Right. So, like every story, it starts with your own personal love story. And I started way back when I was a student. I'm originally from Malaysia, from a rural part of Malaysia, which has now been quite developed. So you see my own journey. Getting involved in public health sort of like run in your DNA and your blood, So I have been involved with the Boy Scouts. I was probably the youngest equivalent of Eagle Scout. It was called the King Scout or Agong Scout in Malaysia. And we were doing community service. And so I had the chance to get an international scholarship to go overseas. And so I was pre-medical at a small liberal arts college in Boston for Harvard, but that was when I got involved with international students, and we were very passionate about wanting to go home to bring our own expertise and to change life here. So in those years, Singapore and Malaysia were still third world, we were third world. We knew that we were as good individually, There's nothing in our genes that say we are inferior, but why is it that our countries and our system have not got the act together? Why is it that we are not as developed as some of the other countries that have gone before us? So my journey around the world has actually exposed me to this sort of comparative perspective. Why is it that some systems do not work? Because the policies are not translated from the science into action, from ideas, into from the bedside, for example, where a lot of this work in the labs have been translated. But at the national level, you have to get the governments to be working and everything to be aligned, whether it's the healthcare system, whether it's the incentives, whether it's the balance between supply and demand, between the different sectors, public, private, and the people sector, and between the different levels. You have to get it all right. So in comparing, and this was my love affair, I started out coming back to Malaysia. My country didn't want me, so I ended up in Singapore. And that was probably the best thing that happened to me, because there was a lot of social experimenting that was happening. And you have a very supportive government that was willing to try it out. So we experimented. So I was very fortunate to be associated first with the comparative health systems that was being done about 30 years ago when I was first in the Ministry of Health. And then a young Minister for Health, Mr. Goh Chok Tong, that became the second Prime Minister later on, and he's now my boss in being the chairman of the board of directors of Lee Kuan Yew School. So I've gone full circle now. He was an economist par excellence, first class honors. So I came from a public health background. I was working in the Ministry of Health. And so an academic, the then professor of public health, asked me when I was speaking to the medical students in the university. I was then in the government, in the Ministry of Health, running health campaigns and so on. Asked me, do you want to be the first health economist in Singapore? We'll send you anywhere in the world, So I jumped at the chance. I was a young man in my 20s, and I said, okay. And so I went to work under the late Professor Brian Abel Smith, the doyen of health economists. And it was very intimidating because he had like 20 over students, and now they are all the top health economists in the world, but he became one of your students. And also the stress is actually very great on us to do a credible PhD research. So my research was on, again, my love story was on the development of the health services in Singapore and Malaysia. Why did we inherit a British type, centrally based, with a taxation system? And because we're exploring different ways in which we can move from central tax financing to diversify it. So we're considering social insurance, we're considering other forms of a mixed system. And eventually I got involved with the Singapore experiment to bring savings in the context of our aging population. So I won't go into the politics of it, because different healthcare financing reflects the priorities of the country, the history, the culture, the political, socio-economic system. I won't go into that because it's really, in the policy area, it is all about political economy. But there's no best way to skin the cat, but there are different ways in which you try to get people to accept it. So that's a lot of public health in action. You know the basic scientific principles, but you have to get all the resources, you have to mobilize public opinion to support the plans, to make sure that this. So I've been involved in some of this work in the region, doing consultancies for WHO, and that has taken me around to all the top centers. But let me just share with you the Singapore story of the last 50 years, and I hope that resonates with the rest of Asia, because this story is very compelling. If you were to go back to Singapore 50 years ago, just after the war, when Singapore was a British colonial state, it was part of Malaysia. You see on the top picture, that's what Chinatown is, slums, bad housing, lousy sanitation. There were like 10 families living in one shop house. It was documented. When we were students doing social medical cases, I was a tutor taking them in. We still had remnants of this, the squalor, the lack of proper waste disposal, poor sanitation. Those were the social determinants that really was responsible for the health success in Singapore. I still remember those days when people had to queue up in a public tap to get the water that was so scarce, because the rest of the water bodies was polluted. So unless you have a total change in the economic environment, with public housing that brings in modern sanitation that can get rid of your waste, you will not have good health. So that's, to me, that's a prerequisite. So a lot of our work in global health then will have to be in the eradication of poverty, in developmental work, in trying to resolve the inequities, inequalities, before we can bring in the science, to translate many of our knowledge into action. So 50 years later, this is the success story behind Singapore, and a lot of it is related to the improvement in the overall social and economic environment, in public housing, in sanitation, in generating incomes, in education, in the changing of the status of women. A lot of people don't know that Singapore in 1960 had a women's charter, which gave basically the same opportunities to women to access education. And so some of our best doctors and our leaders and the educated women who became mothers were responsible for our improvement in maternal and child health. But to cut a long story short, that's last year in our SG50, Singapore 50th anniversary. I was charged to write the Singapore story over what happened the last 50 years. So contrary to all the books that have highlighted the advances in medical science and the science and technology, I actually went back into history, and half of it came from my PhD thesis, which is to say that essentially it was the improvement in public health, in global health, that was responsible. We solved the problem of health by investing in people's environment. Basically, it was the social determinants of health. If I were to go back into what was responsible for the public health success in Singapore, we have the lowest infant mortality rate in the world, below 1 per 1,000 live births. We have now one of the longest life expectancy, 83, catching up with among the top 10. But what is really responsible, underpinning all this, are all those things that I talked about. And when I really look at the evidence, the decline of infectious diseases took place after we had a clean environment, after we had the huge public housing program. So if you ask me, the public housing program was pivotal. It was actually critical for the public health successes in Singapore, because the masses, 80% of the population were resettled into better housing, away from the slums and the squalor that was breeding all the infectious diseases. So overnight, we saw the decline in infectious diseases, even without investing in our hospitals. All right, so that's the first part of it. Then the real investment in health services that came about when the present government decided to spend the money in the things that were cost-effective, immunization programs. So we saw the decline of infectious diseases was when we start implementing BCG for TB, DPT, the triple antigen, and we saw the decline of all those infectious diseases. So overnight, we saw that. So I was looking at the data, and we saw the crossover with the decline of infectious diseases, our young babies were able to survive. Then it is weak. Then we end up with a aging population with the chronic diseases. So when you have a crossover, that's really the stage of development. That's when the country started developing. Of course, the rest of the story is the rise in the income, the job creation, the improvement in living standards, and work conditions, in the food, and so on. So I'm not going to belittle the rest of the contribution to the economy, but in health, what was very, very significant was we actually saw the evidence of decline of infectious diseases when we went for the mass immunization programs, the public health and sanitation, and we saw the correlation with socio-economic indicators. So how did I get from being an administrator in the Ministry of Health, running health campaigns, anti-smoking campaigns, lifestyle campaigns, that was the start at all. How did I get into academia? And then from academia, I got back into health policy work. It has to relate with what we do with our life, So I was very active with the Red Cross as a volunteer. And I'm not trying to oversell the usefulness of having a civil society, because you have government, you have the market, but when the market and the state fails, what do you have? You then have to rely on the third sector. There will be good people in civil society. There are the people who have got a kind heart, the faith-based organization, the grassroots organization. They were already there even before the state came in, or even the market started developing. So we have to tap that power of humanity, people who are humanitarian, like-minded, altruistic people, and we have to mobilize them. So the best healthcare system to me would be able to harness all the collective energies, not only of the state imposing it, not only of the market that have got a profit motive or some other thing, but to get the best out of it all to civil society as well. So a public-private people sector, PPP approach. So I was involved in the Red Cross, and I got to participate in many of the disaster relief missions. And that was my practice in a sense, as a global health person. And then from there, you also do the other work, which is to contribute towards the development of the country in rehabilitation, in trying, in your indirect, if not direct way, of sharing. So back home in Singapore, was the concern of an urban society looking at different ways of tackling affluence and chronic diseases. And then, of course, money becomes very important. So health economics and financing in an urban environment was critical. So I was glad I played a big role in that. And I would say that what we have now in terms of the medical savings, I did a lot of work on it. The way we do our differential pricing in the hospitals, I had a lot to do to come up with some of the original thinking about how to differentiate pricing and to do the income distribution within the hospital system. So I wouldn't want to get into that, except that it's quite complicated, because when you get into health economics and financing and technology assessment, that's my hobby. That's my some people say my real work has become a hobby, but my hobby has become my work in terms of global health through my consultancies with different governments and sharing some of the best practices. And from there, you have to be a little more serious. My little tip for you is that the good intentions, the fantastic thoughts you have, and you see it from real life experiences, has got to be documented, got to be shared. So I used to publish on demand. Anybody who wants me to help, I will just publish in all these lowbrow things that are very localized. But it doesn't help very much, because at the end of the day, who reads it? Your audience is the local community. It's only when you start publishing in the international journals, then you're it. For me, it was by accident. I was invited. So I ended up in the Lancet series. And from then, it sort of launched your global career. Here I became the lead corresponding author, because the lead author was a very prominent Thai epidemiologist, who has retired since then. But he opened the doors in getting the funding, but we did all the work, my team and I from the Lee Kuan Yew School. And so about 7-8 years ago, we came out with the Lancet series, which is the first documentation of the health situation in ASEAN. So we got a Lancet series for China, for India, for Japan, but Southeast Asia has been sort of been neglected. It's always considered as the backwaters, but there are 10 countries here, and we need to document the experiences, the comparative health systems, and the experiences here, and then to be able to share with the rest of the world. There are lots happening here in East Asia and ASEAN that we need to. So from then, let me just give you one quick example on how, as policymakers, they have to rely on evidence, and that's where academics can come in. Students like yourself, this is a very small thing that we did in Singapore. For years, my colleagues was looking at migration and the problems of migrants and foreign workers. And guess what happened? So it was my foreign students who came to me one day and said, "Sir, we want to look at the health of our migrants, our foreign workers who are in construction or domestic workers. They are neglected a lot. You have got first world standards and the best statistics for Singaporeans, but you have got third world conditions for our workers." So it was a very simple study like this. We got a bunch of foreign students. We sent them out to Chinatown, to Little India, and all they did was to document case studies. And one of the case studies, many of you can do this. We went back into the laws and we said the laws had gaps. And this is where we come out with a recommendation of policies like how to plug in the gaps, where the limits and the ceilings were lacking. We came up with some concrete stuff. So he entered a book in some study that we're doing between Asia and Europe. And if Singapore, which is very well governed and small, cannot solve many of these problems, can you imagine how bad it will be for the rest of Asia? Right? So this is just a simple thing in which we work through an established organization to compare Asia and Pacific. So I'm going to say that actually there's a lot you can do for this region, which is on the upswing in ASEAN, which is integrating. So you can do a lot of work to see what are the impact and implications on the health side. And then from there on, we hope that you'll come up with some theoretical paradigms to suggest how can you share the best practices. And so this is my last slide. When SARS hit us, this is the response. There are only two of these masks that work. One is the N95, and one is the overkill, which is for the spaceman. You know, the rest of it don't work at all. Right? So the science have to come into your public health programs and policies to influence it, so that you can do something like when another SARS comes along, emerging infectious disease, our global health community can do something based on the scientific evidence and not based on our tastes and preferences. So I just stop here, and I would like to wish you all the very best in your global health journey. And I hope your own personal love story will be translated one day into helping governments and our people in the region to improve the public health practice. Thank you very much.
Okay, thank you very much for Kai Hong. Very interesting story. Falling in love with global health, hopefully. So we still have a bit of time if you're not too hungry. Any question, comment from floor? Please go to the microphone. Yes, please.
Hi, my name's Sarah. I'm from the University of New South Wales in Australia. My question's to Dr. Una, who presented first, I believe. You mentioned about the change in policy wording for the reproductive health laws and how that has impacted on getting people to change their perspective on it. However, I do believe that the reproductive health law of 2012 does still have some issues with terms of contraception, modern non-abortifacient contraceptions actually being available. I was just wondering what your perspectives and ideas in where that's sitting at the moment and how that's actually going to affect the women and their choices in spacing, as you mentioned, which is what women are starting to want in the Philippines.
Well, I really think the battle for reproductive health in the Philippines, to a certain extent, as far as I'm concerned, is already over, in the sense that there is public support for what we call responsible parenthood rather than family planning. And the reason for that, again, as I said, is changing the public perspective of what you are trying to do. And essentially, it's not population control, but maternal health and good, responsible parenthood. Actually, it was more of a tactical to me. It was a tactical mistake of maybe of our Department of Health, on the TRO that you were insinuating. And the reason for that is because we kind of overlooked that actually what the Supreme Court was saying was just to make sure that there is a proper hearing and of the evaluation of the various contraceptive medicines that were already available in the country for more than several decades. But unfortunately, it was not done. And so the TRO kind of continued. And as I said, to me, it was a strategic mistake. And this is being corrected right now.
Mark Schenker, University of California, Davis. I want to thank the speakers for taking on this important topic. I served for 3 years as Vice Provost for Outreach and Engagement at the university with the goal of trying to get faculty more engaged in public policy and outreach. And one of the things I learned is one of the biggest problems is the institution itself, which doesn't reward or recognize that type of activity. The focus is on primary ideologic research, and that's what's rewarded. And I think this is a real issue because we can't bridge this if the effort isn't rewarded within our institution. So I wonder if any of the speakers have any comment or reflection on that observation.
Hi, Hong. Well, basically, it's easier for academia researchers. We just do research, and we have findings. Then we sell the findings to the government, whether the government take it or not. So that's the question, right? How do they kind of feel appreciated to our hard works or something like that? Dr. Oman?
I've always believed that we need social scientists, anthropologists to help us in crafting our public health problem, especially in countries like the Philippines, what I consider countries with that still belongs to the low middle class or middle class income countries. And the reason for that is because the pressure on us on prioritization is so important. And I think it behooves that whoever would be our minister or secretary of health should have really a very broad view of both preventive and curative and even rehabilitative medicine. I've always said that I'm talking now of the Philippines as we are now considered still a low middle income country. And the debate is more pronounced with regards to whether you put funds on so-called public health or on so-called personal care or hospital care. And for all the previous years, the assumption was that we should put so much attention to infectious diseases. And as a matter of fact, since like my specialty is on the care of chronic diseases, like what I consider, renal care and cardiovascular, as well as what you call now the non-communicable diseases. However, I was surprised actually that WHO gave more importance to what we call non-communicable diseases only in 2010 when I first attended our WHO meeting. And before that, everything was all on infectious diseases or communicable diseases. When actually we have been talking so much of our double burden diseases in countries or in economies of countries like the Philippines. So I think there has to be really for every Minister of Health, especially in the ASEAN countries, where we have Singapore and let's say Taiwan, who are already in the upper economic level, and a good number of us are maybe in the middle or upper middle, and there are still countries that are, especially in Africa, with which you would consider on a low income countries. And I think each country, therefore, is so important to understand the level of their economic situation in prioritizing whatever health problems that faces them. And I think it's very important for all health workers, for us, for those doing researches, to make sure that the priority is consistent with the priority of the need of their particular country.
Thank you, madam. Let's have Kai Hong.
very quickly, just in responding to your question of incentives, aligning the incentives, it's very, very critical. Dr. Ona has spoke about the context of the stages of development. So a lot of my work as a health economist is to actually to apply something that's applicable to the country at the stage of development. So for some countries, no matter how you slice the cake, they're poor, you have to first develop. Then as a middle income country, the inequities widen. So you have to come up with some prepaid financing, whether it's social insurance, to pull the risks and so on. But when it comes to a developed country, then it's a question of consumption versus investment. And a lot of the lifestyle problems are people's own personal responsibility as well as they must take responsibility for financing and the care. And so we cannot displace that because in the Asian culture and the tradition, the family has been involved. So you have to support the family. But as you can say, you can try as much as the state can do as much as you can, pass all the laws, but essentially it's the people's behavior and the norms and how they're going to support each other. So we have to involve the different parties in the name of universal health coverage. You're going to have a one-size-fits-all. We cannot just big government. You're going to just push the market with all the market failures. But even government have their failures, bureaucracy, corruption, and inefficiency. So what else do you have? So we have to get the best, whatever sector it is, public, private, or the people's sector. So when it comes to the alignment of incentives, we all know that when the market fails in the consumption of high-end technical things, then we have to provide the incentives and align those incentives. All right. So some countries would use pricing and charges. Some countries will have to identify it through a means test to make sure that the limited subsidies from the public purse will get to the people of need. So every country must evolve its own acceptable way, politically and socially acceptable way of making sure there's income distribution, making sure people have access so that, say health care will be granted. But people working in global health and public health has always been on the other end, you're not incentivized, you want to do work and to share your knowledge with poor countries, it can never get published. And the elitist traditions is to always reward the best and the brightest. So whether you like it or not, some top name institutions, people in clinical science doing the cutting edge will always get promotion. So we have to satisfy ourselves that we will be slower in the promotion, we will not get the incentives and not at the cutting edge, but we are doing good for humanity, right? So our reward is maybe based on your faith or based on your own personal satisfaction. For example, the little study that we did on migrants eventually entered the Prime Minister's speech, but we're not going to take credit for it, right? But we give it to the bureaucrat who then feed it up to the director who wrote the speech for the Prime Minister. But that created a policy change a few years ago. And it was based on the work of my foreign students, who were not A students, who were actually B students, who but had a passion to identify with their fellow countrymen or women who wanted to show that even in the first world country, you have problems. So we entered the Prime Minister's speech that Singapore is a first world country. We make sure that the people who come in, that we exploit the labor, will also have access to a first-class system. So we are glad to have contributed to that. But we're not going to take credit because the politicians want it, your bosses want it, but you just hope that your work will recognize somewhere in like-minded people like yourself, or maybe it's stored in heaven, Thank you.
Well, I think our time is up and lunch is ready. So thank you for the speakers and for all your participation. Thanks very much. Okay.
Before we formally close for lunch, I'd like to call on Dr. Withers and EVP Ted Erbosa to award certificates to our speakers. And some announcements.
Just one announcement while we're getting ready. So after lunch, we have some interactive sessions that have been scheduled. So we have several working groups as part of our global health program, and you are invited to choose a working group based on whatever interests you may have. There are working groups on mental health, bioethics, environmental health, trade security, migration, global health education, and NCDs and others. And just join the working group, and you're going to spend an hour and a half meeting others and networking and coming up with some plans for the coming year. So after the working groups, after lunch, then you will go to the concurrent panels, also choose whichever panel you would like. And also after lunch, make sure that you take a look at the posters that are being displayed right outside. People put a lot of time and effort into creating these fantastic posters. So please make sure to visit them and take a look. Okay. Yes.
Okay, so we'll be awarding certificates to the moderators first. So we would like to call on Dr. Junko Kiriya, Assistant Professor, University of Tokyo, to please join us on stage to receive a certificate. And also would like to call on Dr. Zhao Xiachen from National Taiwan University to receive his certificate. To receive certificates and tokens from the University of the Philippines. And afterwards, I'll be reading the citation certificate of appreciation. The University of the Philippines and the Association Pacific Rim University award this certificate of appreciation to Curtis Harris National Cancer Institute, United States, for sharing his expertise and knowledge as keynote speaker for the 2017 APRU Global Health Program 11th Conference. And then certificate of appreciation to Merlita Opeña, Chief Research Information Communication Utilization Division, DOST, Philippine Council for Health Research and Development, PCHRD. Also to Clarito Cairo Jr., National Focal Person, Program Manager of DOH, Disease Prevention and Control Bureau. To Professor Martin Wong, Chinese University of Hong Kong. To former Health Secretary Enrique Ona. And certainly not the least, Professor Kai Hong Kwa, Lee Kuan Yew School of Public Policy, National University of Singapore. So thanks very much. Lunch is served. There are posters to be viewed outside. Please make sure that you'll be back for the working group meetings where everybody is invited by 1:30 in the afternoon. Thanks very much.